Abdominal pain is a very common complaint, and the differential diagnosis is wide, ranging from benign to life-threatening conditions. Life-threatening conditions include a ruptured abdominal aortic aneurysm, mesenteric ischemia, perforation anywhere along the gastrointestinal tract, acute bowel obstruction, acute pancreatitis, peritonitis, ectopic pregnancy, ovarian torsion, and myocardial infarction. There are three main types of abdominal pain: visceral, parietal, and referred pain. Visceral pain happens when the nerves that run through the walls of an organ get stretched. The pain isn't usually well localized and feels like a dull ache or cramp. Hollow organs cause an intermittent colicky type of pain, whereas solid organs cause a more constant pain. Sometimes, as a disease evolves, visceral pain can become parietal pain, which is also called somatic pain. That's the pain that results from irritation to the parietal peritoneal wall. Parietal pain is sharp and can be localized by pointing to a specific spot. Finally, there's referred pain, which is when the brain mistakenly identifies pain as coming from one region, like the shoulder, when it's actually coming from a different region, like the diaphragm. Abdominal pain can often be separated into the abdominal area that's involved. Four gut organs, so the stomach, duodenum, pancreas, and biliary tract, cause epigastric pain. Epigastric pain that's associated with bloating, abdominal fullness, heartburn, or nausea is called dyspepsia. And it's generally due to gastroesophageal reflux disease, gastritis, pancreatitis, or peptic ulcer disease, meaning an ulcer of the stomach or duodenum. Left upper quadrant pain can overlap with the causes of epigastric pain, like pancreatitis, which causes pain that radiates to the back, but might also be due to the spleen. Right upper quadrant pain generally involves the liver or biliary tree, like acute hepatitis, gallstones, or acute cholecystitis, but it might radiate to the back or epigastrum. Midgut organs, so the rest of the small intestines, cecum, and appendix, cause periumbilical pain. Acute pain with fever and an elevated white blood cell count suggests appendicitis. Another cause of periumbilical pain might be small bowel obstruction, which can cause vomiting, abdominal distension, and severe constipation. There's also mesenteric ischemia, which is when blood flow to the small intestines is interrupted, typically due to arterial or venous thromboembolism, and might cause severe pain and bloody stools, as well as progressive low blood pressure, rapid heart rate, and ultimately shock. And finally, hindgut organs, so the rest of the large intestines, as well as the intraperitoneal portions of the genitourinary tract, cause pain in the suprapubic or hypogastric area. Here, acute pain with fever and elevated white blood cell count might suggest diverticulitis, while subacute or chronic pain and diarrhea are typical in inflammatory bowel disease. In older adults, pain associated with a change in bowel habits and iron deficiency anemia can be the first signs of colorectal cancer. Lower abdominal pain might also radiate down from the upper abdominal structures or up from the pelvis, like genitourinary causes like cystitis, pyelonephritis, ectopic pregnancy, or ovarian torsion. Some conditions cause diffuse abdominal pain that cannot be localized. A mixture of vomiting and diarrhea can be due to acute infectious gastroenteritis or toxin-mediated food poisoning. On the other hand, celiac disease is generally associated with chronic diarrhea, malabsorption, and in children it can cause a growth delay. A surgical emergency is an abdominal aortic aneurysm that's ruptured. This can cause pain that radiates to the back and a pulsating sensation to the abdomen. The mnemonic OPQRST can be used to help with history taking, especially regarding pain. O stands for onset, whether it was acute, gradual, or an ongoing chronic problem. P stands for provocation and palliation, so whether any movement, pressure, rest, or other factors make the pain better or worse. Q stands for quality, whether the pain is sharp, dull, crushing, or burning. It also relates to the pattern, like intermittent, constant, or throbbing. R stands for region and radiation, meaning the location or where the pain is on the body, and whether it radiates or extends to any other areas. S stands for severity, which can be quantified with a score on a scale of 0 to 10, 0 being no pain and 10 being the worst pain possible. And finally, T stands for time, so how long the condition has been going on and if it's changed over time. Associated symptoms can also help narrow the diagnosis. Common ones are nausea, vomiting, constipation, diarrhea, and changes in stool, like the presence of blood or mucus, a foul smell, or changes in stool caliber. In terms of vomiting, bilious vomiting might be caused by an obstruction distal to the duodenum, or there might be hematemesis from an upper gastrointestinal bleed. A gastrointestinal bleed might also cause melena or hematochezia. In females, it's important to always rule out the possibility of pregnancy. Then we should ask for genitourinary symptoms, like dysuria, frequency, and hematuria, which can happen with a urinary tract infection or kidney stones. Constitutional symptoms like fevers, chills, fatigue, and weight loss would raise concern for an infection, malignancy, or systemic illness, like inflammatory bowel disease. And epigastric pain associated with cardiac risk factors or other symptoms like chest pain, cough, dyspnea, orthopnea, and exertional dyspnea suggest a pulmonary or cardiac cause. To evaluate abdominal pain, the first step is inspection. First, there's the person's general appearance and how they're positioned given their pain. For example, if they're perfectly still in bed with knees bent, that's concerning for peritonitis. Other features include how a person is breathing, as well as signs of abdominal distension and scars from past surgeries. Next is auscultation to hear bowel sounds. Normally there are 2 to 12 medium-pitched gurgles per minute. Decreased bowel sounds or periodic high-pitched bowel sounds over 2 minutes suggest a bowel obstruction or peritonitis. Whereas hyperactive, medium-pitched gurgles are associated with inflammation within the gastrointestinal tract. An abdominal bruit might be heard when there's an abdominal aortic aneurysm. Next, there's percussion. The gastrointestinal tract is normally filled with gas, so percussion creates a tympanitic sound. But if there's tympany over a protuberant abdomen, that indicates air accumulation, which could be due to an intestinal obstruction leading to a distended bowel. On the other hand, dullness is heard when there's fluid or stool accumulation, or when there are enlarged organs like hepatomegaly or splenomegaly. Finally, there's palpation. First lightly and then more deeply, and usually starting away from the area of discomfort. If an individual tightens their abdominal muscles during palpation, that's called guarding, and it's an important and early sign of peritoneal inflammation. Sometimes the guarding can involve just one region, like a diverticular abscess. Other times guarding can be diffuse, like in peritonitis. Blumberg's sign, also referred to as rebound tenderness, refers to palpation and quick release, with pain felt upon release of the pressure, again a sign of peritonitis. Then there's McBurney's sign, which is tenderness at McBurney's point, which is located 1/3 of the distance from the anterior superior iliac spine to the belly button. That's a classic sign of appendicitis. Another sign of appendicitis is Rovsing's sign, which is when palpation of the left lower quadrant causes pain in the right lower quadrant. Then there's Murphy's sign, which is where a hand is placed below the right costal margin at the midclavicular line, when a person breathes out. Then the individual is asked to breathe in. Normally, during inspiration, the lungs move down and that pushes the diaphragm and the abdominal contents down as well. If the person suddenly stops breathing in because of gallbladder tenderness, that's a positive Murphy's sign. Finally, there's the Courvoisier sign, which is when the gallbladder becomes a firm and painless mass, and this can be a sign of malignancy or chronic biliary tree obstruction. Laboratory tests for abdominal pain depend on the suspected cause, but in general they include a complete blood count, a comprehensive metabolic panel to assess electrolyte and fluid balance, creatinine and blood urea nitrogen for kidney function, as well as bilirubin and transaminases for liver function. In addition, a pregnancy test should be checked in all females of childbearing age. Individuals with significant upper or mid-abdominal pain should have an AST and ALT checked to assess liver damage, and a lipase and amylase to assess pancreatic damage. Serum amylase or lipase levels 3 times higher than the upper limit of normal indicate pancreatitis. If appendicitis or peritonitis is suspected, there is usually an elevated white blood cell count. Fecal occult blood testing is often done to look for evidence of gastrointestinal bleeding, which often happens in individuals with diverticulitis or colorectal cancer. Individuals with suspected genitourinary causes should have a urinalysis and culture for cystitis or pyelonephritis. Urinalysis might reveal the presence of pyuria, proteinuria, and hematuria. Finally, imaging can be done. Plain radiographs can be helpful when bowel obstruction or perforation is suspected. When intestinal obstruction happens, both fluid and gas collect in the intestine and produce air fluid levels. On the other hand, free intraperitoneal air will be visible in the case of bowel perforation, and this is called pneumoperitoneum. Radiographs might be done for suspected kidney stones or gallstones. About 90% of kidney stones and about 10% of gallstones have enough calcium to be seen on a radiograph. So although they can help, they're not the best imaging tool for these conditions. Ultrasound is rapid and can be done at the bedside, so it's the study of choice when kidney stones, gallbladder disease, including gallstones, or abdominal aortic aneurysm are suspected. Ultrasound can also provide useful information about other conditions, like ectopic pregnancy, ovarian torsion, hemoperitoneum, pancreatitis, and arterial or venous thromboembolism. If diagnosis remains unclear, an abdominal CT scan can be done. It might show signs of diverticulitis, cancer, or other abdominal masses, as well as vascular conditions like abdominal aortic aneurysm or mesenteric ischemia, since it allows evaluation of the diameter of the lumen, the vessel wall, and the presence of thrombi obstructing the blood flow. Alright, as a quick recap. Abdominal pain is a very common problem with a very wide differential diagnosis. The first step in the evaluation is taking history, including a detailed description of the pain and associated symptoms. The mnemonic OPQRST can be used, where O stands for onset, P stands for provocation and palliation, Q stands for quality, R stands for region and radiation, S stands for severity, and T stands for time. Associated symptoms might include other gastrointestinal symptoms like nausea, vomiting, constipation, diarrhea, and changes in stool, genitourinary symptoms like dysuria, frequency, and hematuria, constitutional symptoms like fevers, chills, fatigue, weight loss, and anorexia, and cardiopulmonary symptoms like cough, shortness of breath, orthopnea, and exertional dyspnea. Then all individuals must get abdominal examination, including inspection of the abdomen and the individual's general appearance, auscultation of bowel sounds, percussion to assess for organomegaly, and palpation to evaluate tenderness. History and abdominal examination guide the choice of further examination. Laboratory tests in general should include a complete blood count and a comprehensive metabolic panel for a rough check of kidney function, liver function, diabetic and parathyroid status, and electrolyte and fluid balance. In addition, pregnancy should be ruled out in women. More specific laboratory tests might include liver function tests like albumin, bilirubin, and transaminases, or pancreatic enzymes like amylase and lipase. Finally, imaging might be used to evaluate abdominal pain, like plain radiographs and ultrasound. If diagnosis remains unclear, then more advanced investigations like CT scan can be done.